Welcome to this home wound care presentation. My name is Mark Coombe and I've been a GP for 25 years, and I've been on the periphery of the management of a number of leg ulcers, but I've struggled really with an understanding of them and really where my input was. And so although this presentation is very much a basic introduction to leg ulcers, it's probably for those people like me who need a refresher. It's also for those people who are just starting in wound care, but it's certainly not for those super experienced nurses who certainly know a lot more about wound care than I do. Why are we covering this? Well, home wound care is all about looking at the best way that we can manage leg ulcers and try and get them better, but also looking at research into what's new and what will really work. I think we've all been frustrated with leg ulcers because we tend to see a large number of people keeping coming back, using huge amounts of resource with expensive dressings and huge amounts of experienced nursing time, and there must be a better way of doing it. So let's start at the beginning. What's the definition? So a leg ulcer is defined as the loss of skin below the knee, on the leg or foot, which take more than 2 weeks to heal. So 2 weeks isn't very long, and in some people it will just be a traumatic event that's caused it, and so it'll be quite a quick turnaround, and in other people it'll be a long chronic condition. So we're lumping quite a lot of stuff all in the same basket. So what are the types? Well, the main type, 60% of all of leg ulcers are venous, and then there's arterial, neuropathic, pressure ulcers, and mixed. Quite often in medicine, we use mixed as a bit of an all-in bag, and it's a bit of a cop-out. But actually, I'm going to try and explain as we go along why mixed may well become more common and why mixed is important. So let's talk about venous ulcers first. Venous ulcers are all about inadequate blood coming back from the periphery of the leg. So everybody knows that blood is taken to the feet by the arteries and it's brought back by the veins, and the veins are helped by various contracting muscles in the calf and the thigh. And so venous ulcers are all about venous hypertension. So for some reason, the venous system in the lower leg is under pressure. When the venous system is under pressure, it causes damage to the little veins and it causes tissue fluid or edema, and as a result that tissue is very poor quality in most people who get leg ulcers. And so the risk factors are all about what is it that triggers this venous hypertension in the lower leg that makes the tissue poor, that even with a small amount of trauma will create an ulcer, but also the tissue is so poor it's not going to heal very well. So almost no matter what you do, unless you sort out the venous hypertension, no matter what you do, this leg ulcer isn't going to heal. So the first risk is obesity, and we know that obesity is increasing throughout the UK. Second is varicose veins. So as well as the muscles pumping the blood back from the periphery, there are also little valves in the vein, and quite often in people they're born without those valves, and so if you see varicose veins in a 20-year-old, or if you see them early in life, then it's often that the valve, particularly around the groin, is missing, and then obviously things like people who are on their feet a lot, the valves can get damaged, and women in pregnancy, the valves can get damaged, and so that would then result in varicose veins, and of course that then stops the blood coming back from the periphery. A past deep vein thrombosis or phlebitis in the leg is quite common, so in the leg that gets the ulcer. Previous damage to the leg, someone who's had a fracture, trauma or surgery. A family history of venous disease is that the classic case that people say the biggest decision in life that you make is who your parents are. The only problem is you don't have much choice in that. So if you've got a family history, there's a good chance that you might get one yourself. Symptoms of venous insufficiency, so leg pain, heavy legs, aching and itching, swelling, skin breakdown, and signs of pigmentation and eczema. And this is because stuff is oozing out the veins due to that hypertension. Then this is going to be another risk factor. Lower socioeconomic class. We've always thought that was a risk factor for venous ulcers, but actually It's not a risk factor, but it is a risk factor for the length of which the venous ulcer continues. Risk for arterial ulcers, basically anything that causes a cardiovascular risk. So, in all of your practices, you're doing Q risks to assess cardiovascular risk, and you're coding it in your templates. So any risk for cardiovascular disease is a risk for an arterial ulcer, and that includes diabetes, coronary heart disease, stroke, TIAs, and hypertension. If you're not sure exactly what goes into Q risk, do have a look at it, because all of those things in there will make you more at risk of arterial ulcers. Immobility and obesity again, and all ulcers are at risk, get more at risk with increasing age. So we're increasing obesity, we're increasing age of our population, so we're going to see more. It's expensive at the moment, and that's only going to get more expensive unless we do something about it. Key features of a venous ulcer: they're usually mid-calf to just below the ankle, and they tend to be on the medial side. There's often peripheral edema, and so what I said about this venous hypertension in the leg, that's causing this fluid to be in the tissues, which once again prevents the healing. So peripheral edema is quite common. Larger and shallower than other types. So it's usually, it starts off small, but suddenly you get quite a big ulcer. Stasis ulcers have a moist granulated base and an irregular border, and the base leaks venous blood. We said about the little veins are engorged and they're damaged, and so they're oozing all the time. And so if you put any pressure on them, if you touched it with a gloved finger, then you would notice that there would be venous blood, which is dark blood, starting to ooze into the base of the ulcer. So varicose veins you can often see in conjunction, and symptoms of varicose veins are often present, and that's back to the venous pigmentation and so on. And mild pain can often be relieved by elevation. So the patient comes in, that you see that they've got an ulcer, you put them on the bed, raise their leg to a reasonable height, and suddenly they say that feels a lot better. What about the key feature of an arterial ulcer? Because clinically, we're going to talk about how you do Dopplers and pressure in the legs. But you've got to think of the clinical picture of ulcers to make the diagnosis. So the key features of arterial ulcers, they're often further down, so around the feet and the toes. They start initially very irregular, but become much more regular with time. The ulcer base is greyish, and when you apply any physical pressure, I said about the venous ulcer, you put your gloved finger on it, and you see dark blood coming out. When you put physical pressure on these, they don't usually bleed. Pain is common at night. So if you think the venous one is, they're elevated their leg at night, so it's unlikely to be uncomfortable at night. With an arterial ulcer, it's likely to be painful. And there's often signs of ischemia. We talked about signs of cardiovascular disease. So signs of ischemia, so poor blood supply, oxygenated blood supply to the periphery. The leg may be quite pale, it may be hairless, there may be a bit of muscle wasting. You may notice a poor pulse either in the back of the foot or around the side, and you may not notice nail dystrophy, so the nails look abnormal. Neuropathic ulcers, once again, this is important to note because of how you're going to manage them, but think about the clinical picture. They're usually deep, they're usually punched out. It looks as if somebody's taken a bite out of the leg. They're often on pressure points. So think about the ankles. Think about the front of the shin. They're often surrounded by chronic inflammation. So almost like an eczema or a dermatitis around the outside. So red and flaky. And the surrounding sensation of the ulcer is, rather than it being painful, is often absent or significantly reduced, and they're painless. Onto pressure ulcers. This is almost a different type of ulcer, isn't it? But they are classified as leg ulcers, so I'm going to talk about them very briefly. And these are the ones where there's been prolonged unrelieved pressure for whatever reason, usually due to prolonged bed rest or being in a wheelchair. And so they're often on bony prominences, once again, heels and ankles. And there's often signs of local ischemia, so the pale looking skin, signs of necrosis, and then the ischemia goes to necrosis, and that then creates an ulcer. So here are a few assessment tricks and tips. Regular measurements of the length and the width of the ulcer are really valuable and really will help you decide, if you're seeing lots of these, what it was like the last time you saw it, whether you're going in the right direction or actually whether it's getting worse. Photography is really useful, and particularly if you can take a photograph with some sort of ruler there so you know exactly what's going on, and it also will give you an idea of the health of around the ulcer, what the base of the ulcer look like. Is the base starting to look healthy and granulated, and is it healing? Assess the surrounding skin, assessing the general odor and signs of infection. It always seems horrible to note the odor because it sounds rude, but actually you're thinking about infection and Pseudomonas. What are the peripheral pulses like and their sensation around the ulcer? So thinking about neuropathic ulcers. And what about the presence of varicose veins or symptoms of those? And what's their BMI and what's their blood pressure? So we're going to talk about ankle brachial pressure index, or the ABPI, and what's the interpretation, and can we use compression? So the one thing that's been shown to be this gold standard for the treatment of varicose, of venous ulcers is compression. So an ABPI of 1 is normal, and compression may be applied between 0.8 and 1, or 0.8 and higher. 0.5 to 0.8, they probably do need to be referred to vascular, although you've got to remember, even NICE say that compression can be used if clinically you've done your assessment, they follow the signs that I talked about, and it's being looked after by somebody who knows what they're doing, so it's under strict supervision. Less than 0.5, it's probably an arterial ulcer, and they should be referred to a vascular clinic to get an underlying diagnosis, and whether or not there's some sort of underlying treatment that needs to be initiated. Greater than 1.3 will suggest some sort of arterial calcification, and there's multiple causes of those. I've put a few there on the slide. And once again, depending on your suspicion or the results of other surrounding blood tests, they may be going to a rheumatologist or to a renal specialist. But the idea of this is that at this point, a decision has been made as to how to manage them. Infections are a big thing. As a GP, I've been asked a lot to come and have a look at ulcers and should they have antibiotics or not. And I think it's very easy in ulcer management, particularly in primary care, to give quite a lot of antibiotics. We need now to think a bit more about antibiotic stewardship, and we need to think a little bit more about whether there clinically are signs of infection. And so what NICE say is that most leg ulcers are not clinically infected, but are likely to be colonized with bacteria. And antibiotics don't help to promote healing when a leg ulcer isn't clinically infected. And so clinical infection, signs of redness, signs of pus, sudden change in smell, the patient feeling unwell, so having a temperature, their pulse has gone up, maybe even their blood pressure has dropped and their saturations are high, but that's on the sort of more severe end. There's no point in microbiology. We've swabbed a lot of leg ulcers in my time, and the problem is by the time the result comes back, you've either needed to treat them anyway, or you haven't treated them, and the result might be quite confusing. So there's no point in microbiology, even the ulcer does seem infected, because it's likely to grow nosocomial bacteria. What does that mean? That means bacteria that have developed in the wound during the treatment, so probably related to what we're doing, as opposed to it being a real bacteria that's colonized in there that caused the ulcer, and if you treat it, then it's going to get better. And it's usually Staphylococcus aureus. So the signs of infection, as I said before, is redness or swelling spreading beyond the ulcer, localized warmth, and increased pain or fever. So what about the treatment of ulcers? This is very controversial, is it? And it's very frustrating, and it takes up a lot of time. And I think it's important to think, what is our goal? What's our goal in the company? We're not looking for a magic bullet. We're looking for things that are going to help. And so success in ulcer healing is very individual, patient specific. So there's not one cure for everything. So there might be a series of things in your armory that you want to use. The key is treating underlying conditions. And we've talked about whether that's cardiovascular disease, whether that's prolonged immobility, whether, and this is probably a bit controversial, whether there's something that actually the patient is getting out by coming to see you in the surgery because they're lonely or they want to talk to somebody. And so actually they're not doing anything at home. They're not elevating their legs. They're sleeping in a chair. Is there something in their psychosocial element that you can correct? Can they go to a local social club? Is there someone who's not medical that could go and visit them? Or can we do something that will make them more motivated not to come into the surgery to speak to you because they really like you? The experience and continuity of the clinicians who were involved in the management is very, very important. And I mentioned me sort of dipping in and out of seeing ulcers and not really having a clear understanding of where we are. And I think that's wrong. It's very difficult with the pressure of general practice to have, a single group of people looking after the same ulcers and giving that continuity to the patients. And that probably is the answer going forward, that this is done by specialist teams. But at the moment we are where we are, so, let's see what we can do. There's a confusing number of dressings, isn't there? I don't know about you, but if you look at the practice accounts for leg ulcer, for the cost of leg ulcer dressings, it's hugely variable between practices and a lot of people using lots of different things, and we need to somehow simplify that. I will tell you that we are planning to go on with a series of podcasts after this and look in much more detail about some of the specialist areas of dressings and, can electrotherapy help? What about automated ABPI? But that's for another time. But there are too many dressings and that should be addressed. Antibiotic stewardship, I've mentioned that already, and we'll probably cover that in a further podcast. There is a need for research, and then is a need. I was reading nice guidance over the last few days, and a lot of it is, we can't advise this because there isn't any research. Well, in that case, then we need to look at it. What about additional treatments? They're coming out all the time, aren't they? Silver, honey, electrical stimulation, maggots, high pressure oxygen. Yes, these all have potential to help us, but we've got to remember that the underlying problem, particularly in venous ulcers, is this venous hypertension. And so unless that leg is up, then it's not going to get better. I was speaking to one of my senior practice nurses the other day about me doing a presentation on venous ulcers, and she said the one thing that definitely cures them is admitting them to hospital. And I said, why do you say that? Is that because the hospital nurses are way better than the community ones? She nearly punched me because actually she said, no, what happens is they get forced to stay in bed and they get forced to elevate their leg. And that enforced rest and elevation is the thing that really makes the difference. So I hope I haven't offended anybody on this presentation, particularly our experienced nurses. I hope it's been a refresher for some of you. And we plan to follow up this presentation with a series of podcasts to discuss related topics in much more detail. And we're going to get some experts in. So experts from different fields to come and talk to us about their view. So thank you very much for listening, and hope to see you again.